you ask the general public who don't know much about Parkinson's, they'll say, oh, it's the one that just has the shakes. And of course, those of you who know it better know that it's far more than that. But in the last 15 years or so, there's become much greater awareness that there's much more to Parkinson's than the movement as well, but there's also these other aspects which we call the cognitive and psychological aspects. And in the trade and at the special meetings, there are, it's called the non-motor symptoms of Parkinson's. And indeed, on Tuesday we'll be going to a meeting in Korea which is about it's specifically dedicated to the non-motor aspects of Parkinson's disease. Now, again, the reason for talking about this is that, in fact, in the later stages of Parkinson's, these components, these non-motor components, actually dominate the picture. And really, they are the aspects that put the greatest stress on the family and the carer, and of course to the person who has Parkinson's. Now, these are quite challenging topics, and so, but I think to actually confront them and talk about them, I'm going to quite frankly talk in terms of discussing their effects on people and on the family. So to begin with, I wanted to talk about definitions, and I'm going to talk about these through a little detail and then wind back as to how they affect Parkinson's. Now, when we talk, this is we the neurologists talk about cognitive functions, we actually think of 5 domains or 5 aspects of the way the top part of the brain, the cortex, works. And that's what we're talking about here, is that walnutty looking thing when you look at the surface of the brain and see pictures of it. It's that top layer which is called the cortex, and its role is to do many of these 5 things, which is paying attention and planning and organising. Together we call them executive function, and they're a very key component that is disturbed in Parkinson's in a way that I'll talk about. Another important domain, not so important in Parkinson's, is disturbance of language. When we talk about language, we're not talking about speech, because speech is the movements or the muscle component of the production of sound. And I've just got a croak in my voice, and that's a distinction of saying that my speech is disturbed. Language is the production of ideas and the content of what we're talking about. And in many other disturbances of cognition, it's a key area which is damaged. Memory is also another part of cognition, and this is well recognised in conditions like Alzheimer's, where brunt of injury occurs in memory. And finally, there are aspects of personality in terms of whether we become reserved or disinhibited, or how we manage the events around us, which are part of cognition. In terms of Parkinson's, there's another area which we need to also deal with, which overlaps with personality, and that's commonly in Parkinson's we call it neuropsychiatry, and that relates to things such as the degree to which people can control impulses. And again, the way I'm going to talk this through, you'll see that this is a fundamental aspect of both the healthy brain and the brain that's affected by Parkinson's disease, is that controlling impulses is a key aspect of cognitive function. But Parkinson's also has troubles with hallucinations and sometimes with paranoia. And finally, there is a psychological aspect, and this is a key component in Parkinson's. There's mood and depression occur in most people, almost all people with Parkinson's disease at some stage in the progress, and it's far more important in Parkinson's than in other diseases which cause a similar effect on function, brain function. And last of all, anxiety, for reasons which we'll talk about, is also a very important part of Parkinson's disease. So when someone with Parkinson's, I'm just going to turn the lights down, I think it might be a bit easier to see. So when someone with Parkinson's disease turns up to the doctor, there's somewhat less, this little graph is here meant to say, well, how bad are your symptoms? And if you're 100%, you're pretty good. And when someone turns up to the doctor, they're a little bit less than 100%. Otherwise, they wouldn't go. So we can think of them being somewhere down here. But as the illness progresses, this gets slowly worse and worse and the symptoms decline. But in actual fact, at the time that people get Parkinson's disease, the number of nerve cells damaged is actually not close to 10% or just a small number. In fact, they're nearly 70% of nerve cells damaged. And so by the time the disease becomes symptomatic, there's been actually a lot of injury to the brain. That means that there is this pre-symptomatic stage, which we don't know about yet. We know it's there because we know that nerve cells are lost, but we don't know how long it lasts. We think it's about 6 to 10 years. And we suspect that there's an earlier stage in which people are at risk of Parkinson's for some reason. Now, I'm not going to talk very much about them, but I wanted to actually spread this out to say is that in terms of the cognitive aspects of Parkinson's, we suspect that they may begin even in this early pre-symptomatic stage. I can talk to you later on if someone wants to ask the questions about this as to why we think this occurs. We don't know whether it's part of the predisposition to Parkinson's, but certainly by the time the illness becomes symptomatic, if one does careful neuropsychological testing, you can show that these components of executive function are already being challenged in Parkinson's disease. But as the disease continues, these become more and more important. The psychological functions, the aspects aren't so important in the pre-symptomatic stage and actually start to become more important in the middle stages. So I'm going to now talk about this particular component of attention and planning in Parkinson's because it's one of the key areas of cognitive function. And to do that, I need to actually explain it a little bit. So we're going to take a diversion and talk a little bit about what we mean by executive function. And to understand that, you need to actually have some idea of what we mean by attention and working memory. Now, while I'm doing that, can you pay attention to this telephone number? It's part of what we're going to attend to. Just try and remember it. But working memory actually isn't part of memory. It's the sort of thing that allows you to look at a telephone number like this long enough to dial it up. And if someone talks to you, it's gone, and you have to go back and look it up again. So it's not actually memory, it's what we call attention or working memory. It's the scratch pad of the brain. Now, did you remember the number? How many did? Well, you weren't paying attention to me. That's the number for those of you who didn't know. So the way we test working memory is we ask someone to take 7 from 100, and then 7 from that answer, and 7 from that, at least do it 5 times, and then count how many times do people get it right. Now, if your working memory is particularly good, you'll get down to 65 accurately. We don't get too fussed if you're a little bit out, made 1 or 2 errors along the way, but we expect you to get most of them right. The other thing we can do is ask people to spell world backwards. And again, we'd expect most people to get all of the letters in the right order, but not always. Now, I want to give you another test. Can you do them both together? I'd be very surprised if you can. And that's because that's the whole point about working memory. It's what you're paying attention to, and you can't, most of us can't pay attention to 2 things at once. Allegedly women can, but even women will have trouble with this task. And the reason being is that the way we look at working memory is that it's, if you ask someone to look up a telephone number, they can remember 6 or 7 digits. But if you're actually talking about doing a task, most people can really only do 1 complex task at a time, or perhaps 2 or 3 if they're not very complex. And the reason this is occurring is because our frontal lobes, their job is, and the way to actually explain this is to think about what happens when you learn to drive a car. So when you're first beginning to drive a car, all of your attention is directed to getting the gear and the clutch and the handbrake and everything working properly. And you can't pay attention to where you're driving it, who you're driving over, who you're driving around, or why you're going there. But once you've actually made it automated, you can then use it to pay attention to driving in the traffic. So that making things automated is a key component of the way our brain works. And if we didn't do this, we would have to have a very much bigger brain, because all of the front part of our brain is directed towards paying attention and having automatic functions. And that's why you learn the times tables, so that they become automatic, so that you can think about the thing you're going to use the times table for. And so many tasks depend on us becoming automated so that we can pay attention to the purpose of the task. Now you need a key chemical called dopamine to make things automatic. So this young lady learning to drive is using dopamine to make it automatic. Once it's automatic, she calls on dopamine so that she can navigate the traffic and do all the things that she needs to do, use the car trip for. When you've got deficiency of dopamine, such as in Parkinson's, it becomes much more difficult to do these automatic movements. So when the working memory and attention is working well, what it allows us to do is make the balance between persisting at a task and not being distracted versus, and we call that stimulus suppression, and so people with attention deficit disorder have trouble there. Or on the other hand, if people tend to repeat the task and keep on doing the same old thing even though they should switch to something new, we call that perseveration. And so it's balancing between these two things which actually leads to good functional behaviour, trying to on one hand not to be distracted and not on the other hand just to keep doing the same old thing because that's what your routine is. Now, this ability to stick at a task is why we wait in queues, because what we're doing is we're delaying gratification. We all want to be like this lady, not wait and get on with it and get a cup of coffee. And so people who have poor impulse control can't actually delay what they're doing and stick at the task and do it. But on the other hand, if you try and do too many tasks at once, you load up your working memory and actually you're not able to stick the task and you get distracted and in fact you don't complete it very well. In fact, these people tend to do the thing that they learn to do well. So this lady will keep on driving the car and not notice the stop sign because she's learned to just keep on driving the car because her working memory is distracted. Now, the reason I'm telling you this is because in Parkinson's, at least in the early stages, there's a deficiency of dopamine. That means that the working memory is not working at its efficiency level and people are a little bit more likely to get distracted or to perseverate in tasks. And so how does that show up? Well, it means that you can look at a job and you can see that there ought to be a solution here. It's hard to actually tie them all together, nut your way through it in the way that you're used to. So you're just not as nimble at problem solving and you're more likely to get distracted by the things around you. Just not as efficient at doing the tasks. And I'm just repeating myself here, so we see a degree of impulsivity and we see perseverative behaviour, that is, people get stuck in the room and tend to have their habits much stronger than they used to do and do it in the same way even though there might be a better way of solving it, and they have difficulty working out how to solve the problem. Now, the other issue which I'm going to come to later on is that after the first few years of treatment of Parkinson's disease, the mechanisms of controlling dopamine when the drugs are given mean that too much people are going through passages of time where on one hand they may have too little dopamine, and that's when the tremors and the slowness comes out, and then they take their medications and then they get abnormal involuntary movements called dyskinesia, and at that time there's too much dopamine in the brain. And when you have too much dopamine in the brain, people become impulsive and more readily distractible. And so you have these fluctuations between, on one hand, the problems of executive function, which is too low dopamine, but on the other hand, the problems of impulsivity because of too much dopamine in the brain. An analogy is that all drugs of addiction work by increasing dopamine in the brain. What they produce then is a degree of impulsivity and perseverative behaviour. In other words, they want to do the same habit over and over and over again. And so addictions and compulsive behaviours are linked very similarly in this way. So how does this link into Parkinson's? Well, we can think of there being 3 stages, and I'm repeating myself a little bit here. This is in the symptomatic stage. We're not talking about the pre-symptomatic time. And in the first few years, people turn up to the doctor with slowness of movement because of too little dopamine in the brain. The treatments are very effective. They usually reverse the problems pretty effectively, and they also improve the thinking pretty effectively. So there isn't too much disability in these first 3 to 6 years. However, at some point along the way, medications stop lasting as long as they used to, and people notice that in fact they're wearing off after about 4 or 5 hours and you need to go to more frequent doses. And at that stage, that's the sign that the dopamine levels are beginning to go up and down in the brain in association with each medication. And this is where we begin to see more and more problems with both cognitive function and also the mood and psychological effects. In the last few years, there's a significant problem with the dopamine not working at all, and other factors come in so that there's medications don't work well, people begin to fall, but it's also when the neuropsychiatry problems become important, and I'm going to go through each of these stages in detail now. So we mentioned before that executive function, it's not up to par here, but many people are able to keep working, and they may not feel they're quite as nimble thinking as they used to be, but people around you wouldn't really think that there's a big problem. But it's really in this middle stage that the problems are beginning to become a bit more apparent about being able to navigate a way through a complex problem. And as I said before, anxiety and depression become a key issue at this stage. Finally, or not finally, but in this part of this discussion, is that this is also when the impulse control disorders occur. And the way they manifest is that there are these key issues which are associated with high levels of dopamine. Gambling and sex mostly affects men. Eating and shopping mainly affects women. But most people who end up with a lot of dyskinesia have some of these to some degree. Also have things such as obsessive cleaning or obsessive repetition of tasks, and some things we call punding, which is repetitions of the same motor activity for actually no useful purpose. And these all come together with the dopamine levels peaking in the brain at the time of the dose. So let me run through what happens. In the middle stages, the medications are not lasting as long. So someone gets up in the morning and they've got symptoms of slowness of movement and Parkinsonism there. Take their medications, and after about 3/4 of an hour they begin to work. And at that stage the slowness of movement goes away, and often, and in people who have this, involuntary movements start to occur. Now the involuntary movements are typically associated with too much dopamine in the brain, as we talked about before, and that's when these problems are most likely to become manifest again. After about 2 or 3 hours, the dopamine levels begin to start to fall. That's when anxiety and depression begins to occur, and people can have these fluctuations of anxiety and depression throughout the day. And people will often find that they're actually, this is more important with them saying, look, the drugs are not beginning to work and I'm not really quite as well as I should be, and leads them to start looking for more medications. And it's not dissimilar to what happens with people who have a drug addiction problem. It's the same thing where the brain works a little bit too fast and a bit aggressively at the peak dose, and as the levels are falling, people feel a bit unhappy, usually get quite anxious, and it can be that they start looking to need more medications to take. Now, these are not trivial problems in the sense that, and it's not sort of a moral issue of saying, well, does it really matter if someone spends a bit of time at the pokies or spends too much time on the internet looking at porn. That's not really the problem. The difficulty is that these behaviours begin to, they're one of the most important things about stressing family relationships. People can spend very, very large amounts of money. Many of you will be aware of the politician in Tasmania who ended up in a serious sex case, almost certainly attributable to the effects of the medications. And when the medications were lowered, it was clear that he looked back on it and said, well, look, this just isn't me. And that's the problem with these being coming to the fore. And I think that some of them they sort of sound all, you know, a little bit laughable and sort of excessive eating and so on, but they are seriously disruptive to social life, and that's why they become very important and they cause distress to the family. Like many other addictive behaviours, they're often hidden. People are not confident to talk about them, and if they're not actually discussed by the doctor, people wouldn't think of them as being a side effect of the medication. It's not something they would actually think to be a medication side effect. And so, again, knowing about them, being aware of them, and having a degree of openness in the family and with your doctor is an important way of actually ameliorating at least the effects of these problems. So, what can you do to deal with executive function? First thing to do is to try and reduce complexity. So again, for those of you who haven't got Parkinson's, if you think about the situation where you've just taken an overnight airline flight, you've landed in a French airport, you've got to get to the other side, and the plane was late. So you're tired, your brain isn't working properly, in other words, your working memory isn't working properly. You're anxious, affects your working memory. You can't speak the language, or you don't understand what people are saying to you. All of these affect your working memory. So you make silly decisions. You can't nut out quite what to do, and you hasten, and retrospectively you look back and say, oh look, if I'd just taken the time, I would have done X, Y, Z, and it all would have been straightforward. And that's the point. People whose working memory isn't working so well are a bit working under that circumstances of being a bit stressed all the time. And so if you have a big family do at Christmas time and everyone's talking and the noise is going on and all's going on, it just becomes too much and people begin to cognitively sag under that pressure. If you can actually decompress it, keep it simpler, a little less going on, try and nut things out when you're not anxious and beforehand, and if you're someone who's caring, help the discussion to be only have these discussions at times where it's easy to do it without ratcheting up the stress too much. So there's no point in saying on the tram, look, I told you to bring the money, it would have worked, we would have been able to do this, and going on, and it's just not going to solve it, it's going to make it a whole lot worse. So decompress, make it much less complex. Second is treat depression. This is a constant, even if it's not frank depression, but low mood is a constant companion of Parkinson's disease. It doesn't mean that it needs to be strict, but if it's not looked at quickly, it does mean that in fact it begins to have an effect on people's lifestyle and may need medications. And really it's the way of actually looking at it with all mental health issues. Anticipate it, look to see that it's coming by all the normal steps in how do you know that someone's depressed. Well, in an older person, by that I mean someone my age, we tend not to be depressed in the way in which the television shows. Men in particular, their response to depression is to withdraw and take a view that, oh well, people wouldn't be interested in me, and pull back and not engage and not participate. They also become flat, and as I'm going to talk a bit about in a minute, become a little apathetic as well. And it's hard to know whether this is the disease or the depression. So the signs of lack of engagement, lack of interest, and pulling back and not feeling like anyone would really want to talk to me. You know, why do I want to go there? They don't want to see me. I'm just going to rabbit on about what I always rabbit on about, you know, etc. That pulling back is a mark of low mood, particularly in the older person, particularly the older male. What do? Well, in fact, you face it in almost the other way around. Take steps to re-engage, talk to the people that matter to you, do things that you think are worth doing. So, I mean, it's hard for me to tell you what they would do because the things I like doing are probably going to be different to anyone else. But people do like to have engagement with other people, participate in hobbies, visit the family, look after the grandchildren, and even if you're illness gets in the way of you taking responsibilities, it's the positive engagement that becomes very important at maintaining mood and also maintaining some degree of hope. Sleep is a serious corroder of mood, and sleep goes haywire in Parkinson's disease. People don't sleep well during the night because of the illness itself, because of the disturbance of sleep-wake cycle. They don't sleep well because their bladder is less stable and they're having to get up and down all the time. They don't sleep well because their joints hurt more because they can't roll over and move as much. So all of those lead to disturbed nighttime sleep, which lowers mood, and increased daytime sleep, which causes apathy and lack of engagement. So steps to talk to people about how you can actually address this by improving bladder function, looking at pain medication to help with the joints. In other words, identifying the targets that are causing the sleep disturbance. We can't solve it, but we can go a long way towards improving it. Finally, antidepressants are important, but again, antidepressants are involved. In Parkinson's, we're not very keen on the ones that are most popular, that is the Prozac family-like drugs, because they interfere with the way dopamine's released. Secondly, they're not so good with dealing with anxiety. So we actually like some of the older fashioned drugs, which actually have a much more anti-anxiolytic effect if we're going to use an anti-Parkinson's drug. They also have a better effect on sleep. Reducing anxiety, again, is an important factor, and once again, improving sleep is an important issue. And the second is, look to try and control dyskinesia, because I talked about how that is a reflection. It's not that the dyskinesia is the worry, but it's the marker that dopamine's going up and down in the brain, and therefore there will be up and down falls in anxiety and mood. So we look to try and control that, and there's many ways that that can be done. And tonight's not really the time to talk about it, but it may mean that that's where you have to step up to more advanced therapies like deep brain stimulation or infusions of drugs like apomorphine or duodopa. Once again, it may be necessary, particularly in the late stages of the disease where there's more severe effects on cognition, to use drugs like alprazolam. This is a short-acting version of Valium and is a very good drug for treating depression, treating anxiety, but we use one that deliberately only lasts a short period of time for people who get particularly anxious late in the evening or at times where the medications have dropped quite markedly. I've talked before about the importance of recognising the problem in impulse control as the first step to trying to treat it. The second is to try and avoid the drugs such as what we call the D2 agonist class, but the most important one in Australia is Ciprol, because these are particularly potent at causing impulse control problems. And again, to treat sleep problem, but for a different reason. What happens most of all, particularly more to men, but a little bit to people who have a cleaning problem, is that they delay going to bed because the computer's in the room or the iPad. So they spend time on the iPad, either gambling, looking up porn, or other people who have a cleaning will get the vacuum cleaner going at 2 at night and start working away. And this is not a good way to get to sleep, but it also increases the likelihood of compulsive behaviour. Now, closely linked to these high medications is this problem of neuropsychiatry. And this tends to occur really on the transition of stage 2 to stage 3. And the problems here are really around hallucinations and, if it's left to become severe enough, even a form of psychosis. They typically start with nightmares at night. And we don't know how this works really, but we know that, for example, people who have what are called rapid eye movement sleep disorders often have it many years before they develop Parkinson's disease. And there is something to do with the way that controls our dreaming that is disturbed. But we know that medications taken too late in the evening start to produce these very vivid dreams. The first person to know about it is the spouse who's been kicked in the shins or elbowed as the violent dreams are lived out. But they are often quite frightening and wake the person up. Over a period of time, and if nothing is done with them, these dreams persist into the wakening cycle, and what typically occurs is the dream goes on, someone sees a coat hanging on the back of the door, mistakes it, in the dream it looks like a real person, then that's unclear whether that's a hallucination or really what it is, but this goes on for 5 or 10 minutes and causes quite a drama in the household at 2 in the morning. Eventually, if nothing is done, and sometimes actually with the progression of the disease, many people will get waking hallucinations, and these are very typical for Parkinson's disease. They're different to almost all other hallucinations. They're usually of someone in the room, and the person who knows they're a hallucination at this stage. They're not troubled by them, they're aware that this is somebody else, it's not, something that should be, they're not frightened by it. And the people are talking amongst themselves, and unlike other psychoses, they're not talking at the person or telling them to do things or criticising them. And they're often not very distressing at that stage. Sometimes people see brief flitting shadows that look like a dog is running in the background or something moved, and they're sort of distressed because they think they saw something. And the difficulty at this stage, and to some extent here, is that people have trouble sorting out real noises from imaginary noises. And so sometimes it's the television and they get distressed and anxious by it, but sometimes it's the hallucinations, and of course also they get distressed and anxious because they're not quite sure which is which. Eventually, not always, but in some people this turns into a more what we call a psychosis, in which people are unable to distinguish what's the real thing from what's the imagined thing. Now, the factors which are important in actually making this progression going here is we talked about medications exacerbating the nightmares, and if these are not backed off from or used more carefully, they can lead to the dreams persisting into the waking state. Infections, someone who's managing pretty well like this and then gets an infection, particularly a urinary tract infection or sometimes a chest infection, will end up getting into these until the problem is treated. So if you're managing pretty well and then someone drops into this stage, everyone should be thinking, where's the infection? Now again, older people don't get a temperature often with these infections. And so the thing that we know that something's going wrong is the anxiety and the agitation and the hallucinations, and going off in food a bit. Poor sleep, again, will lead to some of these problems, and you can see poor sleep is a recurring theme in all of these things with cognitive disturbance. And external stressors going on, so if there's upsets in the family or in the social life, all of these actually lead to other events. So how do you treat this problem? Well, again, you address these things carefully. Look out, make sure the medications are optimal, and that often means making a compromise between walking well and moving well to avoid actually these problems disturbing cognition. Look out for infections, try and treat sleep, and reduce stress and decompress things again. Now, the last area I want to talk about is around this area of memory and language, and really the terminology that we use about the term dementia, because in the general public, I think if you ask most people what dementia was, they'd say that's Alzheimer's disease. But to us, in the trade union, we have a slightly different idea about how it works. And this can become a significant problem in this stage. These are not inevitable, but they are an important disturbance in cognition. And you remember I talked about these domains of cognitive function. Well, the problem in 2 of these fits the criteria of dementia. Alzheimer's, it's usually memory and language, and they're the 2 that come to the fore. But for us, at least in Parkinson's, this is the key area up here, and dementia with Lewy bodies, which is really built around this, is the second most common cause of dementia in the community, but not nearly as well recognised. And Alzheimer's disease does occur in Parkinson's. So, dementia with Lewy bodies. Well, first of all, there's the problem of attention and planning that I talked about, but at a level which is actually really beginning to corrode, not just the mild levels, which mean that people are not as nimble in their thinking in the early stages of the disease, but a more significant intrusion in terms of needing other people to help you navigate day-to-day activities. They're frequently linked to these hallucinations, and so when we see someone who's got marked problems here, plus problems of hallucinations, we make the diagnosis of dementia with Lewy bodies, or DLB. Apathy, which is the ability to set things going, is a really big, important component of these stages where dementia comes present. Now, we talked about working memory, and we talked about the idea that people become impulsive, and the other idea is that they perseverate on activities. But when either of them is working at all, at least people do something. They're either impulsive and get going, or they get stuck in the same routine, but they have a routine. But when the frontal lobes stop working very well at all, people lose their self-starter, and they have trouble initiating things, and they sit and won't get going and won't do something. This causes enormous frustration to the family, but it also means that it's we've got to sort out the question of whether this is depression or whether it's related to dementia. Depression is treatable, apathy with dementia isn't, and in fact we do harm by adding too many medications. Now, Alzheimer's disease does occur more commonly in people with Parkinson's disease than in the rest of the community of the same age. Again, I can tell you about the biochemistry of why we think that occurs, but I don't think that's quite the topic tonight. But in fact, it's to do with the basic molecules that are causing mischief in Parkinson's and Alzheimer's seem to be closely related and encourage each other to misbehave. Alzheimer's, the cognitive domains are memory and language, but when it's present with Parkinson's, it's got this slightly different flavour of having a bit of executive control function. But we make the diagnosis when memory and language are the most important part of the kind of cognitive function, and it's overshadowing the executive component, or there's no hallucinations present. Once again, apathy is a key component of it. So what can you do? Well, again, it's going to sound like I'm on a recurring thing here. Make things simple. Try and reduce the complexities of things, because it increases anxiety, and the anxiety then leads to more trouble with the managing the hallucinations. Try and reduce changes in the environment. So sometimes where people have been being looked after in someone else's household, so one of the children are sharing the looking after, and they stay the night, that shifting the place where the person sleeps is a very good way of stirring up hallucinations. And try and keep the environment and the routine and the processes, again, as familiar and as normal as possible. This is a way of reducing complexity. Also goes for the level of lighting. If the lights are on, make them bright so everyone can see what's going on, and reduce the shadows. And when people are sleeping, make sure that they're not complete darkness, but you can actually make out what the room looks like if you wake up. Look for the causes we talked about, such as infections and drugs, and see if you can change them. And these may be other drugs that aren't just for Parkinson's, things like antidepressant drugs, some blood pressure drugs. There's a number of things which can actually interact and interfere with cognitive function and hallucinations. Sundowning is the problem of where the hallucinations come at the time when the sun sets. And we don't know why that is, but it's a very common time for this to occur. And again, managing the day at that time, keeping it relatively simple and giving support to the person will reduce the effect of the hallucinations. Medications such as Seroquel, which is the brand name for an antipsychotic without very strong action on the dopamine system, can be quite helpful in reducing the severity of hallucinations as well. We've talked before about managing the agitation and anxiety, and it's the same process in the late stages where anxiety occurs early on. Now, when dementia is present or hallucinations is present, this is the time where the strain on the carer becomes most marked. And Parkinson's is an interesting condition because I have to say that I can't think of another condition in which people come to the clinic and they're usually married to the person that they've been married to for a long, long time. There's something unusual about Parkinson's, about this diligence in social relationships. But the reason I'm raising it now is because people are also conscious that they've got into the bargain till death do us part. And so the idea that they have an obligation to do their best for their spouse is very, very strong in Parkinson's, which is laudable and fantastic for the person who has Parkinson's. But the problem for everybody is that, and this is what I run into as a doctor, is encouraging people to share the load, because if you do it all yourself, you're going to be worn out and nobody else, and things will come to all end in tears much faster than you would otherwise want. So it's important that if your intention is to stay at home as long as possible, that you seek help early and don't get yourself tired out. So use the respite care facilities. That doesn't mean necessarily staying in them, but it means getting someone to look after you, either in a formal sense or an informal sense, so you can go shopping, have time to yourself, even just allowing, to go and do the things you need to do and just clear your brain so you're not always worried about what the other person is doing. And also, you need to look after your own mental health. It's a time where depression and anxiety in the carer can become very important, and that, again, if the object is to ensure that people stay at home as long as possible, that's really a key thing that one must avoid the carer running out of petrol, either emotionally or physically. What determines the need for a nursing home? Because this is part of the fear and the stress that comes in there. So there are really 3 reasons why people end up not being able to stay at home. And cognition is one of the most important ones. So people who end up with one of the dementias, particularly if there's a neuropsychiatry element, it just becomes too hard for one person to do it. And the stress is that if you don't get help at this stage, then actually you'll have a risk of causing harm to the person you're caring for as well as the carer. Falls are the other factor, which means that it's very difficult to continue caring at home unless you find some other way of looking at how to get someone off the floor without damaging the back of the carer. I think at this stage it's very important that you plan contingencies. What are you going to do when this time comes? How are you going to manage it? And it really comes down to the resources that you have available. And by that, it don't just mean money. Some people have children who can come to participate and help, or extended members of the family who can do it. But it's all of those factors which are going to determine whether, in fact, this is something that can be done as long as possible, or whether you're going to have to call in formal help early. It's easiest to do this before things have actually started to seriously unravel. And so I think that it's best at this stage if you talk early and get involved and get some degree with everybody, and particularly both the person affected and the person doing the caring, to say how we're going to manage this if the time comes. It's not will, it's if. Lastly, but it's getting near the last, apathy is a really important thing, as I mentioned before. First of all, make sure that it's not depression. Secondly, try and stimulate the activity by having a regular routine that engages people rather than just allowing them to sleep a long time and not be engaged. But don't get frustrated and angry. It's one of the key reasons that the carer gets irritated and annoyed and tries to say, no, come on, you can do better. You know you did. You did it the other day. Why can't you, etc. And that is a very unhelpful situation for both of you, because everyone gets angry and upset, and it leads to worsening cognitive function. Now, this is the last slide. One of the things that, and again I did promise that this would be quite frank, one of the problems with Parkinson's disease is that I think that there's too long been a little bit of dancing around the facts by saying people don't die from Parkinson's, they die with Parkinson's. Now, I think that's incorrect. People do die from Parkinson's in the same way as they die from Alzheimer's disease. And by not looking that unfortunate fact in the eye, it means that you take away choices for yourself. You do have choices about how this is going to occur, and you can only exercise those choices if you have discussions both with your medical advisors and within the family about how you can take them and how you can deal with the medical juggernaut, which will just go on its own way and do what it does unless you step in and say, that's not how I want it to be. Now, you really do have choices there, but you can't do them until you think it through and decide what it is you want to do. And you can ask your neurologist will usually be willing to engage you in that and say, well, these are the things you can do, and that's how you can do it the way you want to do it. So I think that's where I should finish. I've left the normal slide up there, which is the Parkinson's registry. We're still looking for recruits to join it. If you think you would like to participate, either as a control or a person with Parkinson's disease, contact Sarah and we'll spell out the details of what the engagement is and whether you think it's for you or not. So I'm open to questions.
The symptoms of hallucinations and paranoia, are they manifest later in the drug disease process, or can they appear earlier before formal diagnosis?
So this is, again, an issue of semantics. If it's what we call idiopathic Parkinson's disease, which is what we think is the real Parkinson's, then it's a late problem. It occurs in the last 3 to 5 years of life and doesn't occur early on. And in fact, if it does occur early on, then we don't think we've got the right diagnosis. But there are cousins of Parkinson's disease in which it can occur early on, and dementia with Lewy bodies can occur as a standalone entity and present with hallucinations. And so we would then be saying, well, look, we think this is DLB, and sometimes dementia with Lewy bodies doesn't actually have any Parkinsonism at all. And so I know it sounds like we're splitting hairs a bit, but that's the
Can there be a misdiagnosis in diagnosing Parkinson's disease and still have symptomatic symptoms of the disease?
So I think I know what you're asking. So first of all, coming back to a little bit of the question you were saying before with what do we actually mean by Parkinson's disease. So there are two separate things. One's called Parkinsonism, and that's the symptoms of slowness of movement, which we call bradykinesia, but that's the thing that leads to the shuffling gait and the slow steps and trouble with the fingers moving quickly and the soft voice, difficulty rolling over the bed, etc. And there are many conditions that can cause that. Some of them are reversible, some of them aren't. Parkinson's is one of them. Parkinson's disease proper is just one of them. And there's a number of reasons that we can say early on where we can say, well, look, I'm pretty certain we've got idiopathic Parkinson's, which is its proper name. And that's usually things such as the disease is asymmetric, it's worse on one side than the other. There's very little in the way of cognitive troubles that we've talked about here, and you've got to look hard using neuropsychology tests to see them. The nature of the tremor, the response to medications, there's a range of things that says we think that's what it is. Nevertheless, when you look at big studies where there's been postmortems at the end of it all, the misdiagnosis at the outset of the disease, even by places where they're very good neurologists, is around about 10%. So yes, it can be something that isn't Parkinson's, even though you've got those features.
So how do you get it right then?
Sorry?
Like, how does it get right?
Well, this is
a client that's got purely the dyskinesia, none of the cognitive functions.
only got dyskinesia.
I mean, sorry, she's got all the movement problems.
Yeah.
No, she's 100% with a millimetre.
Yeah, so this is one of the big challenges. We haven't got a diagnostic test. So there's a couple of things you can do. We can do PET scans. So if someone's got a reduced dopamine in the brain on a PET scan, that helps to actually clarify whether that's idiopathic Parkinson's or a dopamine deficient form of Parkinsonism. The other thing that you can do is simply wait, because the passage of time usually makes it clear which way it is. Now, to some extent it's a bit academic, because what are we going to do? We're going to actually try and treat the movement disorder in the best way we can in response to the anti-dopamine drugs or the dopamine drugs. If they don't work, then we're going to back off them. If they cause side effects, you're going to back off them. So I think you can make the diagnosis if you think that by doing tests, if you really think that there's going to be a big decision on the basis of it, but most of the time there isn't a big decision. So we usually say, if I was in that situation where I was unsure, I'd actually tell you, I'm unsure. We'll have to wait and see what happens. Because there isn't any disease-modifying drugs, we can say that we're going to actually say, well, if we knew that, we would have gone this way. We're actually going to treat the symptoms. Any other questions? We'll let you go and start tonight. Okay, thank you very much.